This is Dr. Raj. This is Dr. Rajkumar here. On behalf of Vadodara Psychiatric Society, I welcome you all for the 6th CME fortnightly meeting that we are having. And the topic for the day is case-based discussion on positive symptoms. The meeting will go in this manner. Divya Sharma from Jaipur will be presenting 2 cases. After each case, Dr. Bhaskar Mukherjee as well as Dr. Malay Dave will initiate the discussions. Any of you participants wish to ask a question or clarify something, you can raise your hand and ask the questions. We will be addressing them there and there itself. In case there is something you want to put on the chat box, it is welcome. The meeting is going to be recorded. There is a link which will be given, which will have a list of all the previous sessions recorded. So anyone can access it at any point of time for reference also. With these, I hand over the stage to Divya. Dr. Divya, please take over.
Thank you, sir. Good evening, everyone present here. I'm going to present the clinical cases which has been given to me by Dr. Bhaskar Mukherjee. It's a real world scenario where we cannot just apply any guidelines. So there was, one second. So this is a case about Mrs. AB, who is 43 years old female, who presented to the OPD with long-standing history of auditory hallucination, which were primarily persecutory and accusatory in nature. She also had severe social withdrawal and cognitive dysfunction in form of inability to calculate simple mental maths, inability to understand complex ethical reasoning, and inability to comprehend series of tasks. Her symptoms started at the age of 25 after birth of her first child. She has been treated by multiple psychiatrists with different antipsychotics over the years, but mostly the treatment hasn't worked much. Slowly, her symptoms progressed, and despite treatment, she developed severe functional limitation. When she presented to the clinic, she was taking clozapine 400 mg, lithium sustained release 400 mg, lamotrigine 200 mg, and modafinil 200 mg. After detailed childhood and early adulthood history from the mother and the husband, it was found that she had severe obsessive anxious tendencies since childhood with multiple phobias. After marriage, the tendencies increased more and more. The first pregnancy was lost to abortion, so was the second pregnancy. Both were first trimester abortions. At the onset of illness, there was prolonged insomnia and low mood and excessive anxiety, which was followed by paranoia and hallucination. Family history found genetic loading for malignancies in paternal side. Father and 2 of his brothers died of pancreatic cancer, and 1 aunt died of ovarian cancer. In mother's side, there is preponderance of obsessive and compulsive tendencies and addiction, and few completed suicides. Armed with her background history, the treatment was started. We kept clozapine in slowly reducing schedule of 50 mg every 20 days with a target dose of 100 to 50 mg. Modafinil was converted to as and when required dosing. Lamotrigine was down titrated by 50 mg per 20 days with a target of omission. Fluoxamine was introduced and kept on 50 mg per 10 days, up titration schedule with a target dose of 300 mg. She was also given propanol because of 120 resting heart rate. Then we kept her on once in 2 month visit, which were with monthly telephonic reporting by husband. The first month reporting, which was via telephone, husband reported that she's doing better. Hallucinations has reduced in intensity and frequency, and she was able to do basic household tasks. Rest remained the same. After 2 months, when the patient first came physically in the first follow-up, it was reported the auditory hallucinations were very much reduced. Her fear was less. Her mood was better. Mental maths became doable if it was easy and could follow structured logic and orders. She was accompanied by her daughter, this time, who reported that her mother started inquiring about her well being and her college life. Patient was still getting confused with complex intellectual questions and still has a lot of cognitive dysfunctions and confusions. She was on fluvoxamine 300, propanol 60, clozapine 250, lithium sustained release 400. This visit dose reduction was continued and fluvoxamine was increased to 400. Rest was kept the same and was again called after 2 months. After 4 months, in the second follow up, she was the main informant this time. Auditory hallucinations were gone, but at times she was still ruminating about those thoughts and she could give full description of her initial episode. As per patient, the self blame and hate started after the abortions and increased during the third pregnancy. At that time, she also started obsessing over what would people say about her and do things to her if this pregnancy too got lost. The thoughts and the purpureal state overwhelmed her, and the behavior disturbances started. This time, she was able to do every household activity and task, started reintegrating with society, still socially inhibited, but can engage with others outside family in meaningful conversation if necessary. She was on fluvoxamine 400, clozapine 100, lithium SR 400, and propanol 60. We reduced the clozapine further to 50 and kept it fixed there. We added Mementin 10 milligram and kept it in an incremental schedule with 10 mg increase every 20 days. Target dose was 30 mg. Rest was kept the same. This time she was called after 4 months. 6 months, that is the third follow-up, there was a full return to normalcy. No residual abnormalities were there. Since then, she is on a 6 monthly follow-up, and it has been 6 years since she came into her contact. She is now post-menopausal. Only once her mild symptoms in the form of recurring thoughts has returned when she had her menopause, but it resolved with temporary increase in clozapine 200 milligram for 6 months. In fact, she brought her daughter for treatment when her daughter destabilized. The first case is done here.
So, to summarize the case, initially the patient was clozapine resistant schizophrenia within inverted comma, and then there was no response to various other measures. And with this state, her treatment was started. She was not tagged with clozapine resistant schizophrenia tag. Rather, some other formulation were started. The question was started whether hallucination is the sensory phenomena or it is a compulsive obsessive phenomena, and based on that her treatment was reorganized. Clozapine and antipsychotics started getting reduced. Various antidepressants were started to be given. When there was initial improvement, this line of treatment was followed, and ultimately she did extremely well and is doing extremely well with 50 milligram clozapine, which was much higher before, and 400 milligram fluvoxamine, 20 milligram memantin, and lithium. And presently, she, although is taking the medication, is at a normal functional level, as normal as can be expected from any woman who is doing well postmenopausally. So, this is the case format. Now, I would like everyone to ask your question. And I would wait for 10 minutes or 5 minutes. If no question comes, we would start discussing amongst ourselves. Although I sincerely hope, yes, there is one question from Dr. Nachiketa Desai. Why fluoxamine? It is just that initially it was thought that as clozapine is not working much, so let's give clozapine a dose hike. And that dose hike was given in form of adding fluvoxamine. We all know fluvoxamine being a very good inhibitor of CYP1A2 would block clozapine metabolism, and that would give clozapine level higher. But with the improvement and with the various functional changes, clozapine augmentation never became the goal anymore. Rather, adding and increasing fluvoxamine to obsessive level and treating her as a case of obsession gone through wrong treatment pathway became the priority. So this was the answer to Dr. Nachiketa Desai. And
So,
I am pleased to see there are other questions.
yeah. On this fluoxamine question, my
Hmm.
question would be, let's say if not fluoxamine, the other part,
Hmm.
could any SSRI would have been uh, equally successful had we,
Possibly.
uh, yeah, because that's
Very well get, possibly, because fluvoxamine was actually just application based on our previous knowledge that fluvoxamine inhibits partially clozapine metabolism and gives a higher serum level. So fluvoxamine was initially added to increase clozapine level and make clozapine work better. But when actual anti-obsessive action started, then it was understood that it is the anti-obsessive action that is doing the trick. So standing there is no reason why other drugs could not do the same. Clozapine, fluvoxamine was just so-called Modle guideline indication.
okay. Now there are a few questions related to the use of lithium in this patient. I'll take them one by one.
Hmm.
Why was lithium given in the first place? This is asked by Dr. Jaya Jacob.
Hmm.
Dr. Divay Mangla says, why was lithium continued?
Hmm.
So also Dr. Anshika asks,
Hmm.
reason for continuing lithium SR 400. Dr. Amrit Bodani asks, can we taper down lithium and omit it completely?
Hmm.
Um, yes. So these are the questions related to lithium. Why? First part being, why was
Hmm.
lithium started? Second, why was lithium continued at a certain dose? In your case, 400 mg.
Hmm.
And the third part is, can we continue? I mean, do we need to continue the same, or do we want to do away with lithium completely? So three parts.
Lithium was added as a safeguard. Initially, lithium was added as a safeguard of getting activation and making this case stamped as schizoaffective. I don't want, didn't want the patient to get another additional tag. Later, when the patient got completely well around post-menopause, I once tried to reduce lithium. Reduction of lithium has done something peculiar, has made the patient feel dysphoric, has made the patient having more rumination, has made the patient having decreased motivation to work. So on the basis of that, lithium 400 was continued. Yes, I can do it lithium 300, and in future probably I would do it lithium 300, because 400 SR and lithium 300 doesn't really has much difference in terms of pharmacodynamics. The only difference is pharmacokinetic. So this was the reason for me to continue lithium. I have tried to reduce once and the patient didn't tolerate it well.
On that lithium thing and mood stabilizers or whatever we want to call it, why do you think lamotrigine was given?
Lamotrigine was given because that the persons who tried to treat me, this patient before me, they were following Maudsley guidelines. In Maudsley, lamotrigine is the first molecule that should be given once clozapine trial for actually doesn't work. So this is probably the reason lamotrigine was given. As to the cause of why lamotrigine didn't work and lithium worked, I would say lamotrigine is not mood stabilizer, mood is not voltage. Similarly, lithium is not mood stabilizer. It is just that lithium has additional properties in brain's neuro immune reaction modulation, which is not there in lamotrigine so far as our knowledge concerns. That is why lithium, by modulating the neuroimmune reaction, probably has made the hyperactive circuit of rumination slightly low, whereas lamotrigine couldn't cut this cheese. But this would all be a speculation, because we are talking about four different things here. Whenever we are talking about brain, we are talking about four trains going in four different directions, maintaining equilibrium. One train is the physical connections in brain. For example, cerebellum is connected to brainstem physically. Basal ganglia is connected to thalamus physically. Amygdala is physically connected to thalamus. There are various such physical neuronal tracts that are there, that are the high speed neuronal pathway that are extensively used by brain. This is number one train, number one thing that we need to consider. Number two is the functional networks. These functional networks cannot be seen in neuroanatomical dissection. These functional networks form when we do some work, be it cognitive, be it motor, be it
थोड़ा चाय बनवा
anything
दे
else. वहां पे in this, I have been muted too. In this functional network, the connections are formed preferentially, means some part of anterior cingulate uh, cortex has to connect with insula, but that connection fiber is not physically present. But to do anything, these two structure has to be connected to monitor anything, to do anything with concentration, to do anything or to stop anything with concentration and things like that. This is number two. Number three is the vast level of molecular neuroscience things. I would call molecular neuroscience net. Each synaptic firing, each cell to cell connection has a vast molecular neuroscience underpinning, and that is the third trend that is going in a different direction, but that has to be there within this balance. And the fourth one is dynamic instantaneous adjustment of the first three trends. Whenever there is any change in body or any change in the external environment surrounding the brain. So until and unless we solve these four trends, it is impossible to say why one drug worked in one area and why one drug didn't work one area. That is number one. Number two, all the theories that we talk, the current invoice theory is neurotransmitter soup of brain or brain alphabet soup, which actually doesn't exist. That would only be broken when we can show these four chains and things like that. I know
Okay.
I have gone a little, but
No
this
problem.
is to be understood that whatever we are saying is actually a educated guess estimate, nothing more than that.
Okay. We have got a few questions related to the hallucinations that this patient had,
Hmm.
and I'll take them one by one. And again, it's a kind of a pattern of questions. So Dr. Peer Bansal asks, what is the nature or quality of hallucinations? That's one. Dr. Jadeja asks, does that mean that the auditory hallucinations that we encounter in clinical practice are mostly self-centered obsessive rumination?
Hmm.
Dr. Divay Mangla asks, again, the same thing. Auditory hallucinations are extreme manifestation of obsessive tendencies.
Hmm.
Right. So basically, what is the exact nature of hallucinations that we see in so-called psychotic patients? What is it actually?
We have actually detailed it in the Brain on Wednesday series, probably number 4.
The last one.
The generation of positive symptoms and how they are generated. In a very schematic way, to generate hallucination, there has to be something in the background, that is a tendency to overvalue things or overvalue, or to tendency to have a opinion favored more than other opinions. This is a normal common human trait. But this trait first gets exaggerated, then this trait gets converted to various forms of delusion due to incorrect executive circuit input, incorrect motivational circuit input, and incorrect inhibitory tone input. Then these patients who have various delusions, they also, if they also have associated sensory discrimination abnormalities, sensory integration abnormalities, and various absence of various checks and balance in the long run, the long range sensory modalities like visual or auditory, then they would progress from delusion to hallucination. So hallucination is actually a very intricate disturbance of a so-called psychological term, imagery formation.
Okay. Where was I? Okay. So, yeah. So then again, there are few questions related to fluoxamine.
Hmm.
Dr. Deepak Gormode asked how fluoxetine led to improvement. I think you answered that in the first part. Dr.
Hmm.
Pfizer asked, does fluoxamine, the SSRIs which inhibit drug metabolism in general, and in this case clozapine, because that was the thinking, would it increase the risk of seizures in the patients? That's one.
Yes,
Uh,
that would definitely increase, but yeah, it didn't.
yeah. So there is a chance that it may increase the in a vulnerable patient the onset of seizures.
Hmm. Hmm.
Um, Dr. Jaya Jacob asks, can the dose of fluoxamine be reduced once the symptoms subside? So we are talking of hallucinations here.
If a patient who has severe hallucination, which were refractory to all the so-called antipsychotic, responds to any SSRI, be it fluvoxamine, be it sertraline, be it escitalopram, then the first thing is to keep the patient at that dose for as long as possible, because it is one of the proof that this is a phenomena which has its root in obsessive pathology. And in obsessive pathology, once we achieve remission, we seldom reduce the dose. We very rarely reduce the dose where patients got symptomatic recovery. So, standing there, I myself have not tried to reduce dose of these people who have got respite from hallucination, long term hallucination, just by using SSRI. You might try. If you get some success, I would be happy to get the feedback, because this is what we are talking about is something groundbreaking. We are talking about normal resistant hallucination not responding to antipsychotic, responding to antidepressant. If any goras really hear this talk, they would be very, very uncomfortable, and they would be very, very angry.
Okay.
So, in
Yeah.
this uncharted area, we are free to reduce the dose. I have not been able to find the courage. If anyone does it and gets something good, I would be happy to know.
So, yeah, I think that also answers Dr. Jacob's next question, that is there something like a maintenance dose? So I think that you have answered it well, saying that
Yes.
whatever dose has given improvement, we go along with that dose and try not to reduce it
Disturb the
at least
equilibrium.
very quickly. Let it
Hmm.
be in a stable state.
Hmm.
Dr. Rajkumar asks, how soon do we start fluoxamine in cases of wherever there are auditory hallucinations which are presenting alone or in an acute psychotic episode? Here, the case that was presented was, long term.
How?
I mean, a very chronic kind of a case with some response, no response, and going on and on. But if it's something like
Hmm.
a very acute onset psychosis, short duration of symptoms, what would be your take on that?
We
Regarding fluoxamine.
uh, we be it fluvoxamine, be it antidepressant, any antidepressant, if we want to use them in hallucination, the hallucination should be first shown to be not responding to antipsychotic or getting worsened by antipsychotic. Number one. Number two, they should be of sufficient, some sufficient duration. Let's say patient is having a 15 days hallucination, and we are going to try any antidepressant on it, probably the best idea is to first try psychotic better, because antipsychotics by their nature reduce neuronal transmission, neuronal excitability, mostly excitability. So they have a chance of managing the minor dysfunction of sensory integration, minor dysfunction of which actually various forms of sensory and perception problem. If they are not able to do it, then we should add antidepressants as second line.
So not to rush into adding an an SSRI right from day one in an acute or a
Yes.
short duration psychosis.
Yes.
Okay. Okay.
Otherwise, we would be actually blaming the SSRI later.
For increasing, yeah, that's true.
Yes.
That's true. So yeah, Dr. Jadeja has given something more about his experience on first episode sudden onset psychosis, basically with auditory hallucinations only in a 60-year-old female. All the elements of the sensory experience confirms that it is an auditory hallucinations. Can this patient benefit from SSRI?
Sudden onset, 60 years female, first episode, we should first check about sensory neural deafness in ears, because actually sensory in elderly, female, male, anyone, if we get that there is sudden onset, first episode psychosis, and it is not progressing usually, then first we check his ear, and if a ear is not affected, or if not there is not any tinnitus like sensation, then we have to treat it via first antipsychotic, intolerant, antidepressant. Because ultimately we are dealing with a neurodegenerative disease. This is a neurodegenerative disease.
Can everybody please be on mute? It's very distressing.
Yeah.
It's very distressing. It's time to global mute.
Yeah, mute everyone, please. Just yeah, please mute everyone.
Yes.
Amrish, can you mute everyone?
Yes.
Okay. So yes. So right. Okay. So yes. So whenever there is an acute presentation, it's better to start with antipsychotics and then see
antipsychotic, then see what happens. If needed, then ideally antidepressant.
Okay, Dr. Vaibhavi asks a question, but before her question, there is one more which I shouldn't miss. How soon? Okay. Yeah. So Dr. Vaibhavi's question is, given the chronicity of the patient that was presented, aren't there going to be disturbances in the endocrine or immune axis? That's one. What about the risk of this patient of developing dementia? And any studies to quantify if duration of treatment would delay the onset of the same?
First question is, there is definite neuroendocrine and immune system dysfunction. Otherwise, this disease would never have happened. Anything that starts in brain disturbs neuroendocrine and neuroimmune system, which later spill over to general endocrine and general immune system. So yes, there must be. Number two is the risk of dementia. Yes, definitely there. There is going to be risk of dementia. Every patient of this type would get risk of dementia.
Okay.
Third, there is a third question I couldn't hear.
any studies to quantify if duration of treatment would delay the onset of the same? Means if there is, for example, a lot of delay in presentation to the psychiatrist.
There is actually one was duration of untreated psychosis was highlighted for a long time before we started understanding duration of untreated psychosis is probably not that important. Now, there is a recent trend, of publishing studies which shows antidepressants delay onset of dementia. Like duration of untreated psychosis, here also there is a nagging question. How we know which person is going to develop dementia and which person is not going to develop dementia, because dementia is not a single disease. So by continuing lifelong antidepressant, are we really preventing dementia or delaying dementia? That we don't know, because dementia, until and unless we break down dementia, bring out the 10 to 15 crore disease that is hiding inside them, and follow their natural evolution, we cannot probably answer this. But I hope, and I sincerely have some nagging suspicion, that antidepressants, lithium, they probably slow some of the natural progression. Not very much, not reverse, but they probably slow.
Okay. So the last couple of questions I'll take, and then we'll go to the next case. What do you think is the
Dr. Divamangla is asking on a actually axis about I see that.
we'll come to that. So there are two sets of questions. One is Dr. Ajay Kumar asks, what is the role of propranolol? That's one. And what is the role of modafinil? So these two drugs.
Modafinil was not started by me. Modafinil was going on because she was sleepy most of the time. Propranolol was given because of extreme tachycardia. The tachycardia was more than 120. So propranolol has to be given.
Okay. A couple of questions by Dr. Divya Mangla. One is, what is the state of attention traits in this case? That's one. And another one is, what is the importance of history of malignancy in this family? She mentioned quite a bit of concentration of psychiatric as well as other non-communicable diseases, including malignancy. So what is the importance of this? So two things from the history. What is the status of attention, inattention, or whatever way we want to put it? And what is the importance of this history of malignancy? And the third thing that he asked, and I think that we have covered time and again in this, is that so OCD is a harbinger of psychosis. So every psychosis be treated with antidepressants. I think we talked about that, what is happening. So we'll not get into that again. But yes, these two questions are important.
So attention deficit is also part of the whole psychosis symptomatology. Once we go to next case, I think we should take this question there, because that would be the better place to answer it. Number one.
Fine.
Number two is, so I am delaying that question for the next case. And what the other question? Other question is
family history of cancers. What is the
malignancies?
importance of?
Malignancies are let's imagine an octopus. Let's imagine an octopus first. Our brain is the octopus, and it sends its arms to all the organs in our body to form sub-brains. Every organ in our body has a brain. In case of heart, it is called intrinsic cardiac nervous system or intrinsic autonomic cardiac nervous system, which works similarly to heart. In case of GI system, it has been over abused and over amplified by calling it second brain. No, it is not second brain. It is just intrinsic autonomous enteric nervous system. Then comes liver, intrinsic autonomous hepatic nervous system. Then comes genitourinary tract, intrinsic autonomous renal and the rest of the genitourinary tract system. And similarly, skin also has such a huge intrinsic autonomous nervous system that probably by sheer number of neurons, it should be called second brain. Anyway, so now if the octopus gets a disease, the from the disease would always touch in the body, but limbs and the extensions would also later suffer from the disease. So if a patient has a disease of brain, then the disease of brain would affect in other areas and in other organs. Brain's action in other organ is supervision of functional status, immune surveillance, surveillance of the organ growth, as well as surveillance of the organ usual degeneration. All of every failure of immune surveillance, every failure of organ degeneration gives rise to cancer. So every brain disease has a close link to cancer. I don't know how much you take history of your patients or how much you take life cycle history of your patients and their relative. If you are very observant, you would find out most of our patients have a history of family history of colonic cancer, liver cancer, lung cancer, blood cancer, generally divided in solid organ cancer and blood cancer. The people with extreme forms of psychosis, bipolar, tends to get more uh, frequent blood cancer, and the people with not that extreme forms of these type of diseases tends to get the various solid organ tumor, including colonic, breast, pancreas, gastrointestinal stromal tumor, adenocarcinoma of esophagus, adenocarcinoma of lungs, and things like that. So they become an important pointer of family genetic load. If your patient says, my family has no psychiatric history, but your family has a lot of malignancy history in the family, that is equals to same as having high family of psychiatric disorder. That is why taking various malignancy history is important in family.
Okay. Now, two people have asked the question on memantine. One is Dr. Ankur Singhal and one is Dr. Sabiullah Sayyed. What is the role of memantine? And can
Memantine was
memantine, just one sec. What is the role of memantine here? And can memantine help in preventing the progression of dementia?
first the easy question. Here, memantine was added because by the time memantine addition was done, she was more or less free of hallucination, but her doubts were remaining. There was much doubts. There was ruminations. So to combat that rumination and doubt, we added memantine. Now the tough question. Would memantine slow down dementia? Nobody knows. We give it and we hope it. But the hope many a time gives us some positive prediction bias, means we hope that memantine is slowing the patient disease and we are giving it. So if the patient lives long, we think that memantine has worked. But the problem comes, dementia is not a single disease. Dementia is not even a disease group. Dementia is just a name. And again, I am saying there are probably 4 to 5 crore diseases hidden inside the tag dementia. They have their own progression, they have their own nature of evolution. Some of them would progress slowly, some of them would progress fast, some of them would progress to rest for some time, then again progress again. And some of them would progress to some extent and then stop. We don't even know in these patients, memantine, we have given memantine, the patient is apparently living longer. Whether it is due to memantine or it is due to the natural evolution of the diseases like that, we can only hope and we can only give. Unfortunately, we are Neanderthal working on working with actually stone weapons, and the thing that we are working on needs something that even current Homo sapiens doesn't have. That is the problem.
Okay.
We can only hope, we can only give, and we pray that this evolution matches with memantine.
Okay. So, right now, just to answer this in very brief so that we can go, do similar justice to the second patient. So, Dr. Jadeja asked, should an asymptomatic normal person with heart rate more than 100 benefit from propranolol?
That the person would benefit from propranolol, that person would benefit from paroxetine, and that person would definitely benefit from checking out the underlying primary attention deficit, secondary obsessive trait in him or her.
Okay. And last question on this, absolutely last question on this. I'm not taking any more if there are still there. So Dr. Ajay Kumar asks, when we start seeing improvement, like in this patient with the change in the medications and all that, what exactly was happening neurobiologically? And if we were to label this case, what will be the nosological place or diagnosis or however you want to put that?
First, let's attempt a easy one. What is the change that is happening inside the brain? The excitability of neurons getting lowered, the extreme hyperactivity of localized circuits getting down, the neuronal stem cells which were not actually doing much. Just a minute, please hold on, please hold on.
Yeah, okay.
Hello.
So Divya, we are
Yeah,
ready with
hello.
the second one.
Yes, sir.
Just
Hello,
give us
hello,
2
hello.
minutes, so then we can get on with it.
Yes, sir.
Yeah.
আপনি দেখুন নিউরোম্যাক্স বলে একটা বড় সাইনবোর্ড লাগানো আছে, তার ভিতর দিয়ে ঢুকে আসুন, ঢুকে এসে রিসেপশনে চলে আসুন। নিউরোম্যাক্স। হুম। So we actually know some of the things that changes that can happen with drugs. The neural stem cells which are exhausted and which are not producing enough cell would start producing cells. Now, what actually would happen in other area? Various other connection abnormalities would get corrected. What is the second question answer? I don't know, because I have forgotten and I have definitely never tried to think about what is the nosology according to DSM and ICD. I have discarded them completely. So it's up to you, whatever nosology you decide.
Okay. So without wasting much time, I think many of the things, many of the concepts that uh, you put up in the last 2 sessions on the positive and the negative symptoms in psychosis, I think with this case things are more clear when we see these things being explained or applied in a real world scenario, so to say. So yes, Dr. Divya, we uh, hand you over the proceedings for the second case. You may start the second one.
Case 2, it's a case of Mr. PN, who was a 47-year-old man who presented to the OPD with complete mutism for the last 5 years. He has been taken to every institution in India for his treatment, but he never spoke in those last 5 years. From ECT to clozapine 900, every single thing was tried in his treatment, but none worked. So the illness started when he was around 35 years of age. He was an outgoing person with many athletic records who used to work as a travel guide and a professional trekker. Around 35 years, he started withdrawing and then started fearing a lot of things. Then he developed paranoia and finally frank hallucinations. There was a history of cannabis abuse in his life. So first, he was treated as based on cannabis-induced psychosis in one of his old treatments. At that time, too, he started refusing food and drinks and went mute. He had to be hospitalized and was given parental nutrition and injectable antipsychotics. He took about 2 months to get better. Then he was kept on olanzapine plus fluoxetine combination and was doing well. But he couldn't really return back to his old profession and became jobless. After 4 years of treatment, he stopped his medication and started operating as a equipment store with his family assistants. The business was doing good. He got married and had a kid. At the age of 42, his symptoms returned again: fear, anxiety, low mood, and paranoid thoughts, finally leading to hallucination. This time, he didn't refuse food or drink, but became completely mute. Every treatment was tried by different institutions, and he responded to nothing. At the time of presentation, he was getting clozapine 300 milligram, escitalopram 40, lamotrigine 300, and risperidone 4 mg. He was completely mute and would not acknowledge anyone or anything, would not ask for food or water. He has otherwise well kept and maintained basic hygiene. We started by omitting risperidone and directly reducing lamotrigine to 100. We added venlafaxine in incremental regime of 75 milligram every 10 days with target of 375 milligram. Added nighttime clonidine for sleep and reduced clozapine to 200. We called him after 2 months with a lot of expectations for venlafaxine breaking the block. First follow-up after 2 months, same pleasantly mute and placid condition. Only noticeable change was he looked at others when called repeatedly. He was on venlafaxine 375 milligram, escitalopram 40, lamotrigine 100, clozapine 200, and clonidine 100 microgram. Since venlafaxine made him look towards the sound, we thought that something more activating would work. We slowly cross-tapered escitalopram with bupropion, and bupropion was scheduled to hike to 450. Like every other psychiatrist, we were worried about the scissors. Therefore, we completely omitted clozapine and gave 5 milligram olanzapine in its place. Clonidine was increased to 200 microgram in hopes of stopping sympathetic overactivation. Lamotrigine was kept at 100 milligram dose. He was again called after 2 months. Due to some family troubles, he missed the 2 months appointment and came back after 4 months, though he was continuing his medication. So after 6 months of treatment, he was being seen this time. The progress was that his vacant look was gone. He was communicating in short, non-verbal gestures, but there was no sound. He did not show any engagement with family, but did respond to basic questions with non-verbal yes or no communication. This thing made one thing was clear about this, like venlafaxine and bupropion combination has done whatever it could. We added atomoxetin to this regime. Incremental dose was planned for this till 80 milligram. He was kept meanwhile fixed on venlafaxine, bupropion and olanzapine doses. Lamotrigine was increased to 300 milligrams slowly because if he had any chance of seizure, then it would take care of that. Clonidine was increased to 300 microgram and he was called after 3 months. After 3 months, he returned. Wife was the first person to announce that he has finally spoken and broke his silence after almost 6 years. His communication was still very nuanced, but he started answering the questions we asked him. Haltingly, but he did answer. This was nothing less than a breakthrough. This time, we instructed the whole family to talk with him regularly and, if possible, all the times he was awake. His atomoxetin was increased to 140 gradually because he was about 100 kgs, and we called him back after 4 months. In the 4 months follow-up, he was speaking normally and he was instructed to start working in shop again. And everything was kept same in his drug regime and we called him after 6 months. On 6 months return visit, he was doing well socially and business-wise. We were out of fear of seizures too, so we gradually omitted lamotrigine over next 6 months and started calling him yearly. Now it has been 10 years. He had first came to us and he's still stable, managing his business. Venlafaxine too was omitted in the follow-ups and he is now completely normal with 80 milligram atomoxetin, 300 milligram bupropion and 2.5 milligram olanzapine. Thank you. This is the second case.
So this is the case for which I didn't answer the question of Dr. Divya Mangala about attention there.
Right. So you can answer now because he has asked a question why atomoxetin was not the first choice in this case.
Let me ask you very frankly, if such a person comes to you and you have seen the extensive treatment history which came as 2 large files, would you be able to fast give atomoxetin?
If you're asking me, definitely no.
Now the question is, this is my first patient of selective mutism who remains mute for 6 years. I have never seen such a patient before. And after him, till date, I have not seen such prolonged mutism till. So he is a one in a lifetime case. And initially, I started thinking that this is a kind of withdrawal, obsessive withdrawal, depressive withdrawal, psychotic withdrawal. So initially, that was the treatment everyone was doing. And that treatment did not really work. I gave venlafaxine thinking that as everybody never really gave venlafaxine in quite good dose, so let's try venlafaxine. Once venlafaxine elicited a mild response and after getting the full dose for a quite good number of period, he actually showed the small response. I started thinking that maybe here we need to address the executive circuit more. And so I then gave bupropion. Patient was getting full dose of venlafaxine. I increased bupropion to the full dose, and patient was getting clozapine. This is a recipe for seizure if patient has any vulnerability. So I had to reduce clozapine. I was really worried about reducing clozapine because so far everyone has treated him as a case of psychosis, positive symptom psychosis, and who has gone mute. So standing there, omitting clozapine completely is going to be called hasty decision, too risky decision, and would be termed a lot of things. But there was no choice. So I reduced clozapine, started olanzapine. With this, he improved further. So I finally got convinced that yes, I am dealing with a psychosis patient, but the main problem is in executive circuit. The executive circuit has gone down. By some mechanism, his executive circuit is not working at all. He is a case of hypofrontality. So then I started using atomoxetine to the full dose, and I am really happy he responded, because if he hadn't responded, the charming people of my state would have instigated this patient to do a actually medical malpractice case against me. There was and there was no way for me to defend it. I have gone against every guideline. I have gone against every so-called theoretical knowledge. That is why atomoxetine was not used first. Atomoxetine was not going to be used till and I saw that all the avenues are exhausted. If I need to save this person, I have to do something that is not written in any book.
Okay. Dr. Ritvik Chatterjee asked, did you consider methylphenidate or modafinil, and would there be
Yes,
any advantages of this in this case?
I considered methylphenidate for 1 week. For 1 week, I was debating methylphenidate or atomoxetine. I was tempted to give methylphenidate, but then I just stopped myself thinking about medical malpractice route, because if methylphenidate, I gave methylphenidate and he just went into a psychotic episode, I would have to face a lot of problems. So atomoxetine was basically reserved second choice. If I get this patient today, I might be tempted to try methylphenidate first. But I know this patient is once in a lifetime patient, so I am not hoping to see another of this patient in future.
Okay. Dr. Irene asks, wouldn't aripiprazole be a better choice in a case where stimulation is needed, uh, better compared with olanzapine? I think olanzapine in this case is 2.5. So whether even better than low dose olanzapine, aripiprazole would have been a better choice.
The thing is, please, my friends in Niemans, do not hate me for this statement. Niemans has made an odd impression that 30 milligram aripiprazole is a stimulant. Aripiprazole is not a stimulant. If aripiprazole was a stimulant, then we would not have been using it as a antipsychotic. we would have been using it as antidepressant. But it is an antipsychotic by fast, by all its definition. Means it is going to slow neuronal transmission. It is going to slow neuronal activation. It is going to slow mitochondrial activation. So if I give aripiprazole low dose, or if I give olanzapine low dose, how much would that matter? Ultimately, I am giving something that is just a drug which would slow neuronal activation, which would slow neuronal mitochondrial fission fusion reaction and oxidative phosphorylation, and ultimately would make the cell more viable and safe from excited toxicity. Aripiprazole would do that job as much as olanzapine. Rather, olanzapine is better because olanzapine has no freak chance of activating autonomic nervous system and giving the patient akathisia at low dose. Again, I am directly apologetic to my nuanced friends, but you have to understand 30 milligram aripiprazole is not antidepressant.
Okay. Dr. Divamangla asks another question here, that many patients diagnosed with chronic schizophrenia stay withdrawn, keep muttering. How do we deal with such kind of presentations, and which circuits are at fault here?
Self-muttering means soliloquy. Soliloquy means they are talking to themselves. If they are talking to themselves, they are expressing rumination in a compulsive fashion. Why not try drugs which work on rumination and compulsion? Drugs which work on OCD.
Okay. So, what circuits are at fault here? If you can just give a brief overview.
Again, this would be a guess estimate. Nobody knows whether I am saying right or no wrong till we start looking at say a neuronal collection in real time and not via neuroimaging, rather directly. Anyway, if these patients are self-muttering, then they are muttering to themselves or actually themselves, but they are thinking that person is someone else. They are repeating a same thought. So this is a circuit of rumination, which in association with motor planning circuit as well as motor execution circuit would produce this kind of behavior. That is why if you see in literature, cuneus and precuneus, the two region of brain which have close association with motor planning, they are involved in this type of self-muttering and self-muttering hallucination. But I have given just an overview, and please don't believe it as gospel truth because we still don't know anything about brain. This is just a formulation at this moment, which would work, which would give you ideas about treatment, but someday or the other, within our lifetime, we have to find something better.
Okay. So, Dr. Belsare asks the same question. Just once more, which drugs would you suggest for self-muttering? The explanation that you gave just now.
Self-muttering is soliloquy.
Yeah.
Soliloquy means rumination is in overdrive. Soliloquy means the verbal production network is in overdrive. Soliloquy means that there is a compulsive expression of rumination. So drugs which works on number one, obsession. Number 2, attention. Number 3, compulsion. All would help.
Okay. Fine. So, so I think Dr. Belsare, the point is that you can use drugs that are SSRIs, you can use atomoxetine, you can use any drugs which would be effective in compulsive behavior. So, I mean, it's not one, but a list of drugs. So that's what Bhaskar is saying. So, Bhaskar, I had a question here. In literature, we come across this term which is called as uh, dopamine supersensitive psychosis, meaning that when we start treating a patient with antipsychotics, there seems to be a subgroup patients that when we increase the dose, the psychosis increases instead of reducing. So how will that come into the picture here? What are we looking at exactly?
That is why this is the one of the best question was, because this is what led me to this discovery. When I started seeing this observation that increasing antipsychotic gives rise to more hallucination in a group of patients. First, I thought that dopamine supersensitivity hypothesis. But after a few months, this makes me feel like I am doing something wrong, because it is not possible for a group of drugs to create hypersensitivity to the mechanism that they are doing. This is wrong. This is grossly wrong. We are thinking something grossly wrong. Then I started forming alternative hypotheses. First, I thought that these drugs stopping the prefrontal cortex or executive network from suppressing the rumination thought. Then I thought, if that is the thing, then that doesn't explain every patient, because yes, there is a group of patients in whom so-called dopamine supersensitivity psychosis start, who develop shows sign of executive dysfunction, but not all patients of dopamine supersensitivity hypothesis, psychosis comes up with the executive dysfunction. So there must be something else. And I started thinking along the line of fast visual imagery. Then I started going back to formation of visual imagery, and then this whole thing is formed. So dopamine supersensitivity hypothesis doesn't exist. What exists is, these are people whose obsessive traits are triggered more and more by antipsychotics, and they go into this type of dopamine supersensitivity psychosis, or their hallucinations increase more with anti uh, psychosis.
So would I be correct in saying that this group of patients who have got the label of supersensitivity psychosis, so as you are saying that with time, with increase, as we keep on increasing the dose to get a better handle over the psychotic symptoms, their obsessive ruminations and all those things increase. But is it so that the
Yes,
antipsychotics that we give are kind of impairing the executive functioning, which kind of controls the other ones?
yes, yes.
Okay. Okay.
So ultimately, that is the thing that is happening. They are obsessive in nature. Their obsessive ruminations are slowly getting increased by antipsychotics in one hand. Then antipsychotic is suppressing the executive control, either visibly or not to that extent, and ultimately we get the clearing up of hallucination. That is
Okay.
what is happening.
Okay. And so would that also explain similarly? I mean, here we are talking, let's say, roughly more of higher cortical functioning, but when it comes to movements, so when we have got a, let's say, dopamine supersensitivity happening, let's say at lower down basal ganglion level, and the circuits which are
Akathisia.
maybe akathisia or even dyskinesias.
Exactly.
Okay.
That
Okay.
is why in tardive dyskinesia, amantadine works much better than other. If it is the way we formulate tardive dyskinesia,
Mm.
dopamine denervation occurs and dyskinesia started. If that is the case, then how come amantadine is coming up with the best treatment for them?
Right. Okay. So, Dr. Jaya Jacob asks, is atomoxetine useful in OCD?
Madam, no simple yes or no answer. What happens is in some group of OCD, there comes a time we understand that the attention problem is there, and in them, adding attention enhancing agent do help getting the OCD under control. But this is not the whole of OCD group, a some small subgroup. In other, it doesn't work.
Okay. Dr. Amrit Bodhani asks, is sensitivity phenomenon that we talked about high dose or related to higher doses or longer duration, both, none? What?
Both.
Okay. Dr. Mangla asks, will catatonia respond to antidepressants? In this case, SSRIs, SNRIs, whatever we have talked about today.
Catatonia prevention can be tried with antidepressant. I don't know what would happen, but active catatonia is a state similar to ventricular tachycardia or ventricular fibrillation. There, we don't have any time. Either we have to give IV drug, which is directly going to suppress the arrhythmia, also known as lorazepam. You can use midazolam. You can use others, or we have to give electric shock so that the pacemakers who are chaotically discharging would go back to their rhythm. Exactly like arrhythmia, tachyarrhythmia of heart, catatonia is tachyarrhythmia of brain.
Yes. Okay. I think that is all with the questions. Yes. So, since there are no more questions, we have had a fantastic discussion on the concepts that we have been kind of trying to understand the last 2 or 3 sessions that Bhaskar has had with us. Well, of course, this opens up new avenues for us to understand not only the pathology of diseases, but also how drugs work, what do they actually do, how do we kind of select a particular molecule, especially when things are not very clear, things are difficult to treat. I'm sure as we go along the series, we'll have more interesting cases, more interesting concepts that we need to understand better. With that, I hand over the mic to Dr. Rajkumar sir. So you're mute.
Thank you, Dr. Bhaskar and Dr. Malay. Thank you, Dr. Divya. Friends, the next session is going to be on the 28th, and the topic is negative and cognitive symptoms, complete reanalysis based on cognitive neuroscience, neuroanatomy, connectonomics, and genetics. It will be on the 28th of February. Till then, bye from here. Good night to all of you.
Good night, sir. Good night, everyone.
Good night and thank you.
Thank you, sir.